Hello, hello. Welcome to Grand Rounds on this Monday afternoon. We are thrilled to welcome back a graduate of our residency program, Dr. Michael Ma. I believe was also a hospitalist here, now a GI hospitalist at Lenox Hill after finishing his gastroenterology fellowship over there. His research interests in advanced endoscopy and third space endoscopy, talking to us today about gastroparesis. I'll let you take it away, Dr. Ma.
Great. Thank you so much for that kind introduction. Let me just screen. Okay, great. So once again, I'm Michael. I felt like it was just yesterday since I was on 18 Bear myself listening to this conference. So thank you so much for having me. Today, I will be talking a little bit about gastroparesis. It's a very challenging clinical diagnosis as well as disease. So I feel like this is very pertinent, especially from both IM as well as GI. I have no financial disclosure or conflict of interest. So, excuse me. Okay, so for the agenda of this talk is as follows. We'll be defining gastroparesis and differentiating this disorder from other central motor disorder of the stomach, particularly functional dyspepsia. We'll review the approach to diagnosis as well as the management of this disease. And I think before we begin, the most important question is really, what is gastroparesis? It's something that is definitely much more broad than the term itself assumes. The definition set by Camilleri's group during their ACG guideline is as follows. Gastroparesis is a motility disorder characterized by symptoms and objective documentation of delayed gastric emptying of solid food without mechanical obstruction, which should be excluded by imaging studies such as upper gastrointestinal endoscopy or radiology. So definitely a very wordy definition and a lot to unpack here. But at the same time, it's actually a very concise approach to a very complex disease. Some of the complexity can be a challenge in breaking down the diagnosis itself, and we'll talk a little bit more about that shortly. Now, a little bit about the prevalence and incidence. Currently, one large study examined the US was noted that there's about 13.8 to 267 per 100,000 adults, and incidence around 1.9 to 6.3. Now, that said, though, there's definitely a lot of challenge in the diagnosis, and a lot of these challenges are that the diagnosis, as mentioned before, is set by the requirement for a dedicated diagnostic study. So this is likely a broad underestimation of the actual prevalence as well as incidence. They do note that there is a higher proportion of female over male, as well as non-Hispanic Blacks over non-Hispanic whites. And the common etiology really includes diabetes, idiopathic, post-surgical, as well as medication-induced. And we're probably going to be seeing a lot more of these medication-induced disease as we start having more and more use of GLP-1 agonists such as Ozempic. The symptomatology for gastroparesis is really between nausea, abdominal pain, vomiting, early satiety, and bloating. With that said, though, just double check. Do you see my slide moving?
No, we just see the slide and it says moderate to severe GERD, so it doesn't pop up.
Okay.
We see the symptoms slide. Yep.
Okay, great. Okay. So the symptoms basically, these are the 5 most prominent symptoms of gastroparesis. With that said, though, up to 25% of patients with gastroparesis also have moderate to severe GERD and severe constipation. And this actually, it becomes a very important point as we start navigating into how to differentiate it from other sensory motor disease of the stomach. But we'll first break down the pathophysiology of gastroparesis. And there's a lot of different ways the literature has described gastroparesis. But that said, though, there's no one cause, rather it's likely all of these combined, and it's a certain spectrum of the symptoms that people are diagnosed with this particular illness. The pathophysiology lies with gastric emptying, gastric accommodation, gastric rhythm, autonomic function, as well as non-gastric motility. Gastric accommodation is really pertinent regarding the ability for the fundus to relax. This is started from the swallowing process, and immediately following that, the vagal innervation lead to nitric oxide mediated relaxation of the fundus. This increased fundic tone later leads to contraction, pushing the food to the pylorus, and generally by doing so, it's also grounding up food to 2 millimeter or less, so into small particles. The impairment of the fundic accommodation lead to all of these issues, particularly with early satiety being the primary symptoms when a patient with purely gastric accommodation issues. And some bench studies have demonstrated particularly low intragastric meal distribution during the immediate imaging with the gastroparesis symptoms in animal study as well. Another component is gastric rhythm. Electrical activity plays a very critical role in the stomach as well. It usually involves 3 slow waves leading to appropriate gastric motility. And up to 16% of the diabetic have normal myoelectrical activity, suggesting that as many as 84% have abnormal activities, suggesting we're probably not capturing the whole picture with the incidence of gastroparesis in diabetics alone. And this also shows that there's multiple different pathways for the different etiologies for gastroparesis, but the overall arching issue is really involving the ability of food passing the pylorus, which we'll talk a little bit more. And once again, another aspect of the autonomic function, particularly parasympathetic function, is required for normal gastric emptying, and this is where the vagus nerve plays a very critical role. It is not only important in accommodation, but also relaxation of the pylorus muscle. And inadvertent vagotomy, it does occur quite often with open surgery, cardiothoracic surgery. So we actually do see at least 3 to 5% of patients undergoing surgery coming out with inadvertent vagotomy and subsequent gastroparesis. This type of issue is also propagated now with more and more lung transplant. There are actually multiple studies looking at concomitant interventions at the time of lung transplant. Lastly, the other component that leads to a lot of this autonomic function is the opiate, which causes decreased gastric motility and increased tonic contraction of the antral muscle and the upper duodenum. So non-gastric motility also plays a very big role, as mentioned before. Common to most patients with gastroparesis is other form of dysmotility in the GI tract. Over 25% will have dysmotility of the small and large intestines. Increased duodenal tone limits gastric emptying, which is commonly seen with Ozempic, and the extragastric dysmotility also suggests other generalized dysfunction of the enteric nervous system. This is very commonly with the radiopaque markers seen in the past, but we also have other diagnostic tools now to identify some of these issues. And it goes to show this comic, when I first read it, didn't really make too much sense, but you can see why it's very important that the whole GI tract is in harmony. And then lastly, the gastric emptying itself. So this is probably one of the most critical part to the diagnosis of gastroparesis. However, commonly, this is not the only issue that leads to the pathology. Gastric emptying is coordinated by multiple neuromuscular coordination that's required to allow the smooth transition of the food through the stomach. Severe delay in gastric emptying are more likely to be associated with this particular symptom of vomiting. So when patients have primary gastric emptying disorder, they will probably be complaining more about vomiting than abdominal pain or bloating, although they do all can occur at the same time. Other recent bench studies have really demonstrated a lot of cellular and molecular components to some of the widespread changes that lead to the pathology itself. Here's a rather busy slide showing just that. We see that not only in diabetic gastroparesis, but also in idiopathic gastroparesis, we're seeing a lot of immune-mediated inflammation leading to a lot of the changes as well as damages in the interstitial cell of Cajal, leading to a lot of these delays in motility. And furthermore, even the matrix of the gastric mucosa, it makes a very important role, particularly with macrophage, fibroblasts, and endothelial cells, leading to this motility. There's a lot of study looking into ways to try to target these particular cellular changes, but so far, nothing has been available clinically yet. So this is one hot topic in gastroparesis, and it's how does it differentiate from functional dyspepsia? And just putting here for the diagnosis, you can see that for the current role criteria for diagnosing functional dyspepsia lies in having one of the following, particularly with postprandial fullness, early satiation, as well as epigastric pain and burning, with no evidence of structural disease, particularly at an upper endoscopy. These criteria need to last for 3 months with symptom onset 6 months prior to diagnosis. So very similar as mentioned before with the postprandial fullness being a common symptom, epigastric pain, the particular GERD component. And what's interesting is that there has been a lot of research looking at how to differentiate the two diseases as the treatment is vastly different. One is more particular pharmacologic, whereas gastroparesis, there are starting to be more and more broader interventions that can be applied. On the left here, we see the overlap between functional dyspepsia as well as gastroparesis, particularly in the etiology, whereas on the right, you see more of the pathophysiology that's leading to the disease. There's a lot of similarity, and there's actually been multiple studies looking at follow-up patients who had diagnostic study demonstrating gastroparesis with follow-up within a few months with improvement in the gastric emptying. So it's there's broader understanding that this is likely somewhat like IBS, where there's a mix type and there's the changes between the two pathology. Unfortunately, the challenge is really that the management is different and it can really delay a lot of diagnostic and interventional approaches that's available in gastroparesis. So the diagnosis. So gastric emptying study is currently the gold standard. The test needs to be at least up to 4 hours, unless 90% of the food has emptied within the 3 hours. The one area that commonly a lot of patients are concerned about is the radiation exposure, and compared to X-ray, it's really only about 4 times, so not significantly more. It has a marked sensitivity as this is one of the primary components in the diagnosis of gastroparesis. However, the specificity actually comes down to 70%, but this needs to be at least 4 hours. One common issue that has caused a lot of false negative has been a lot of institutions only doing less than 4 hours or even 90 minutes for many institutions. So it becomes very important that it is clarified that the study lasts for at least 3 to 4 hours. On the bottom right, you see the timing for the estimation of the emptying of the gastric content and up to 2 hours. Generally, most patients have 0 to 10% at 4 hours. With that said, this study is very, very challenging actually. It requires you to schedule up to 4 hours of your time. Before doing so, you actually need to stop all the medication that may have been helping you up to 48 to 72 hours before the study. The fasting overnight, as well as the glucose testing right before the study, and generally is very important. As much shortly before the study, if it's over 200, generally there is a lot of false positives, which can be very challenging to really enforce during the procedure, as not only would you need a nurse to do this, but you also need a tech there. So a lot of institutional challenge barriers to appropriate diagnosis of gastroparesis. The meal preparation itself is also quite interesting and can vary from institution to institution. For the most part, it's approximately 30% fat to correlate with what normal intake is. It's generally egg white cooked with the sulfur colloid to allow a stable bond, and it's very important it's done around the same time. And it's very important that it's a solid meal, not a liquid meal, as one of the biggest challenge is that the liquid goes through the GI tract a little bit different than solids, particularly in gastroparesis. And generally you want this around 10 minutes to try to keep the study consistent, and insulin can be given during these testing. So one other testing that is not as common is stable isotope breath test. And I guess just for a moment, does anyone know what that may entail? Right, this is kind of interesting because it's actually recommended by guidelines, and it's actually not something that's very common in most institutions. What it is essentially a stable 13C compound that's ingested. It doesn't have any radiation exposure and can even be performed at home. However, this is usually commercially owned testing, and its sensitivity and specificity is actually quite high as well. Unfortunately, just due to the fact that it's really owned by commercially owned, and it's rather difficult to set it up in most offices, it's not a very common testing. And as you see here, it usually comes with food, and then the patient will eat it, and afterward they will submit their breath collection, and then it will be submitted, and basically you will see how long these stable isotope last in the stomach through the breath, and it can help estimate the amount of food in the stomach and essentially correlate with gastroparesis with gastric emptying. Another diagnostic approach would be utilization of wireless motility capsule. These capsules are swallowed in the office and takes about up to 72 to 3 or 4 days essentially. It's able to monitor pressure, temperature, as well as pH, and using these values, it's able to assess its motility through the GI tract. Very similar preparation for the gastric emptying regarding to pre-procedural medication, timing, and the sensitivity is 64 to 81%, so not perfect. And one of the reasons for that is because the capsule, when it's swallowed, it also moves through the GI tract very differently. The mechanism for the stomach to help move the capsule is actually a little bit slower. And what happened is a lot of times you can actually get false positive for some of these wireless capsule, as well as false negative during different timing when it's taken. So not the perfect study. However, one of the benefit of doing this particular study is also examining this motility of the other aspect, or excuse me, the other part of the GI tract, so small bowel, colonic, etc. Endoscopy, which is very common nowadays, is necessary to evaluate for other structural abnormality. Its primary role is to assess the mechanical obstruction aspect, although it has a very low predictive value when they see intragastric content at the time of endoscopy. And the positive predictive value was only 55% when you see food in the stomach, and as well as 32% when the patients don't have actual risk, and goes to show the complexity of just looking at food in the stomach after a certain amount of time. And definitely not the approach other than to make sure there's no other mechanical obstruction leading to some of the symptoms. There are multiple other testing, most of which kind of have fallen out of favor. With that said, though, a lot of these are still used mostly in literature and more for studies of animal models. But we'll talk a little bit more about EndoFlip shortly. So management, how would you approach management? So suppose one of the house staff picked up a new admission with someone coming in multiple frequent admission for nausea, vomiting, known history of gastroparesis. Where would you want to start? Any takers? Okay, so that's all right. Basically, one of the most common things is really assessing some of the risk factors and ways to control it, right? We'll go into a little more detail, but the biggest thing is most people's minds probably Reglan. Definitely the only FDA approved medication, but unfortunately not very good, nor very easy to keep a patient on. But we'll talk a little bit more about that. So before we begin, generally to begin a treatment, you want to first assess the severity of the disease. There's a lot of ways of doing so. There's multiple different scoring systems, all these acronyms, but for the most part, the most common one currently used now is the GCSI, which is the Gastroparesis Cardinal Symptom Index. This is a 9-parameter scoring system looking at nausea, vomiting, postprandial fullness, and early satiety and bloating, and separated into these 3 subgroups to help better characterize the patient, as well as to give you a better understanding of where to approach a lot of the therapies for and individualized for the patients. As mentioned before, a lot of time you're focusing more on the symptoms rather than the overarching disease. To start, nutrition definitely is one of the first line. In the prior guideline was recommended for a low residue diet with low fiber and low fat. Newer recommendations are now recommending small particle and low fat diet. What does that actually mean? So things that are pretty much mashed up or really fine, and a lot of it exclude the following. On the right here, you see the PAGI-SIM, which is another scoring system that actually do include the GCSI ultimately in the questionnaire. And you see in the A group are people with the intervention of being taught how to proceed with a small particle diet. You'll see market improvement at follow-up about 20 weeks. On B, on the other hand, it's we see that patients with just a control diet, and they really don't have much improvement in a lot of the symptom scores. With that said, while this shows us statistical significant changes, the sample is rather small, about 56 patients, though it makes more sense as previously the low fiber was really hard for a lot of the gastroenterologists to swallow, as that's many times what we recommend most of the time for what we eat. So this kind of goes aligned with what we generally recommend and makes a lot more sense. And it seems to definitely have more and more studies looking into this particular issue, and definitely starting to see more and more benefit with recommending this particular diet. That's why the recent guideline in 2020 actually transitioned to this particular recommendation. Next is pharmacologic. As mentioned before, Reglan is the only FDA-approved medication in the US for gastroparesis since 2013. So it's been a very long time since the last guideline, excuse me. It's been around much longer than that. It's a dopamine receptor antagonist that crosses blood-brain barrier, leading to potential CNS adverse effects. The treatment should be around 12 weeks or less, and with the black box warning, unfortunately, of tardive dyskinesia. Currently suspected to be around 1 to 50%, but there's many abstracts suggesting much less. The number is much smaller than that. With that said, the newest, most exciting thing to happen in the FDA-approved space is that there's a nasal formulation in 2020 as another option, but once again, it's quite limiting. And just something to be aware of is headache, fatigue, and dysgeusia. With that said, though, domperidone, which is much more available outside the U.S., is an excellent option for many people who are able to obtain it. Do do suggest that there are benefits. It does not cross the blood-brain barrier, and it's definitely something that some people do go to Canada or get outside the country. With that said, there are some clinical trials looking at alternative formulations. Currently, WashU and some multi-centers are looking into. So hopefully in a few years, we'll have a little bit more options. I will skip talking about erythromycin as one of the issue with that is the tachyphylaxis with the medication. So it's not really something that you would want to recommend outpatient as much as potentially inpatient if this is a acute exacerbation. With that said, the next exciting medication is prucalopride. Unfortunately, it's currently not FDA approved for gastroparesis. However, in patients who also have concomitant constipation, this is actually an excellent medication and can really offer much more sustained symptom control. On the right, a large study by Carbon's group noted that with prucalopride, they did note a significant improvement in overall symptoms, and particularly even more so that it's also seen in global symptom scores. A lot of the studies looking at gastroparesis generally look at certain scales as the difficulty in having such a benefit into improving the full global symptom score. So this is actually very beneficial and definitely something to consider for anyone with chronic idiopathic constipation that can receive the medication. On the other hand, while these medications are very important in terms of motility, a lot of patients are more upset generally with abdominal pain or really nausea and vomiting. And this is where we start looking into antiemetics. Some gastroenterologists are actually using aprepitant, which is really FDA approved for nausea and vomiting, chemotherapy, and post-op. It's an excellent medication for a very short period of time. Generally, you can probably get a patient about 2 or 3 months supply, but after that, it becomes a question about how to continue on this medication. So unfortunately, it's still also a very short-term option. Nortriptyline, which is a tricyclic antidepressant, has been used in a lot of sensorimotor dysfunction of the stomach, such as IBS. Actually has been looked upon significantly. Unfortunately, currently, there has been no study that shows any significant difference in global score. However, in one particular study, they did show that there has been abdominal pain improvement, although the primary endpoint was really looking at global score. So was really hidden in the study. Definitely an option if the patient's primary complaint is abdominal pain. Now, the next area of topic I want to talk about is pyloric therapy. Pyloric therapy is definitely one area that a lot of us in going to advanced endoscopy are really excited about, as there's a lot of current therapeutic options. One of which is intrapyloric injection of Botox. Endoscopic injection usually includes about 100 to 200 units of Botox to the pylorus injected during endoscopy at the 4th quadrant. Initial open label trial did demonstrate improvement in numerous patients in the first 6 weeks. And this is also demonstrated in subsequent scintigraphy studies. With that said, though, randomized controlled trial in 2007-2010 demonstrated no difference compared to placebo, and it kind of fell out of favor. But with recently, as things started to change, as we started using other technologies to try to identify which patient is more likely to benefit from this particular treatment or pyloric therapies. With that said, though, the current guideline in 2022 is that it is not recommended based on the 2 particular randomized trials at this time. So going a little bit more into the patient selection, we need to talk a little bit about endoflim. It's a high resolution impedance planometry that measures the luminal geometry, as well as the pressure during a volume control distension. What that means is during endoscopy, we'll first visualize for any structural abnormality, excuse me. Follow that, we use this catheter with multiple sensor at the tip with a balloon. We place it directly without visualization, and we can visualize the GJ on the right with the red spot looking to really try to place in the middle. We start distending it with up to around 70 millimeter of fluid to identify just how much pressure is needed and how much it distends following those pressure are placed. It's usually more utilized in esophageal disorders, particularly looking at achalasia. However, its application has been utilized in pyloric disease, and particularly looking at selecting for patients who potentially have a better outcome with Botox injection of the pylorus. And this particular study by Desprez in 2019 demonstrated that in 35 patients with varying etiology to their gastroparesis, they had altered pyloric distensibility, and they actually had improvement after Botox injection. So there's starting to be a lot of studies starting to look into the role of EndoFlip in identifying the correct patient population that would benefit from this procedure. You also have to consider the fact that this is a procedure that generally lasts for at least 6 months. It's about 10-15 minutes. The injection of the Botox probably add another 10 minutes. So it's a very short procedure for a very sustained outcome. So it's definitely something that leads to a lot of gastroenterologists to try to revive this process, hopefully utilize this even as potential to help select for other therapy in patients who do respond to Botox injections. And then this goes to the next area that we've been trying to really look into is GPOM. GPOM has actually been first performed in 2013, and it utilizes the idea of dirt space endoscopy by tunneling through the submucosa to access the pylorus muscle, leading to pyloromyotomy. It's really, many people have different ways of approaching it, but it's really big 5 concept of submucosal injection, followed by the submucosal incision, the tunneling, and then the myotomy, followed by the closure. So here we have a video, and I'll go through it a little. So here you see this is Moyen's group from Johns Hopkins. They start by injecting the mucosa near about 6 centimeters generally away from the pylorus. By injecting this gives a safe margin for accessing the submucosa. And you see they start opening up the mucosotomy so that they can access it with the endoscopy to undergo it. Here he's gonna dissect this some more so that you can start tunneling. And what that means is essentially moving into the submucosal space as shown right here. And we also have a distal cap, which is this clear cap here that helps really move things away so that there's a area for us to work with. And this procedure, you slowly dissect through the submucosal space. You inject with fluid or to really keep that margin open for you so that you can continue dissecting through until you reach the pylorus. And here you start to see the pylorus muscle at the 6 o'clock area slowly being revealed and creating a margin for the dissection. And once that margin is created, you see this white, very nice, fine, kind of like a calamari appearance to it. And the goal of it is to have a good dissection. There's multiple different techniques. Some endoscopists are using 1 mucosotomy and other are doing 2. And there are many different variations, including consideration for repeat procedure in the lesser curvature versus greater curvature. So there's a lot of different application of this technique at this time. And once the pylorus, the pyloric myotomy is performed, the procedure is complete, and it becomes just very important to have a good closure so that that area is completely closed up and you don't have to worry about any other aspect of the myotomy. Okay. So the reason why we started doing this is really because multiple prospective studies demonstrating significant improvement with clinical success at 12 months. Unfortunately, one of the biggest challenges, as mentioned before, is that the patient selection is very difficult as the significant amount of overlaps from functional dyspepsia to GPOM and the variation between the two diseases. So it's suspected that the initial prospective study with 56% clinical success at 12 months likely is in part due to patient selection. One particular study, which included Lenox Hill, was a multi-center prospective study looking at 75 patients and followed for 12 months. They included all three types of the most common etiology, being idiopathic, post-surgical, and diabetics. And they did see that at least 56% had at least one score decrease, and overall scoring system with more than 25% decrease in at least two of the previous mentioned subscales in the GCSI. While that study was very helpful in trying to just prove a concept, making sure that there is actually benefit in a large portion of population, recent sham study came out by Martinek's group at Czech Republic, and it actually was a sham study randomizing patients with refractory gastroparesis defined as symptom greater than 6 months with a GCSI greater than 2.3. So that's the global symptom score. Diagnosed with a gastric emptying study, so gold standard. 41 patients were randomized into whether they get GPOM or sham group. And the sham group, essentially what they did was they actually underwent endoscopy for a set amount of times, around 50 minutes. And the GPOM group would just undergo the GPOM. They would be followed for 6 months. And as you see on the right, there's actually a significant improvement in the GCSI in the group with the GPOM, and even the group with the crossover from patients who had the initial sham procedure. They actually allowed them, went into a crossover and had the GPOM performed and also noted a significant improvement. And one of the most remarkable thing was most studies are actually looking at 1 point in particular subgroup, whereas this particular study actually noted 50% improvement in the GCSI, which is one of the more significant amount of improvement noted compared to most studies currently available. And this is again demonstrated in the gastric scintigraphy shown here in the GPOM group as well as the crossover GPOM group. And we also see that the sham group, just by having the sham procedure, there is a modest improvement, really not much, but there was some changes, so rather interesting. And they do see that a lot with a lot of the functional disorders. That's why this particular study is really eye-opening. Now, moving away a little bit more into gastric electrical stimulators. It's not FDA approved, but it's been around since 2000 and really requires humanitarian exemption to be used. It's implanted using laparotomy or a laparoscopic approach where two leads are fixed to the muscle. And the stimulator transmit a high frequency, low energy impulse to restore the slow wave that was previously discussed. While many of the study did not show any significant improvement in the global symptom score, recent large prospective registry as well as a RCT in 2020 demonstrated improvement in nausea. And this data really kind of shows the importance of really applying everything. And we are seeing a lot of these studies coming out. Even recent DDW conference, we do see that there has been a few more studies looking at the role of gastric electrical stimulator in the management of gastroparesis. Lastly, refractory disease that is not amenable to any of these management techniques are actually undergo surgical intervention, whether that be some form of venting, jejunostomy, gastrostomy, to even distal gastrectomy, and ultimately removal of the pylorus or even surgical pyloromyotomy. So there's a couple of other surgical techniques that are available, although this has definitely decreased in application with more and more broader use of endoscopic techniques. So conclusion. So once again, a little bit of everything we kind of mentioned is again kind of detailed in this very thorough gastroparesis guideline 2022 by the ACG. And it goes through having a detailed history, excluding other potential causes that can lead to improvements such as opiate use. It leads to a diagnosis, particularly looking at GES as well as the stable isotope breath test. Followed by management, starting with dietary modification to pharmacological treatment, and then ultimately nutritional support and the non-pharmacological treatment. One area that I didn't mention too much is that a lot of patients with gastroparesis initially thought to be usually not able to tolerate PO, very malnutritious, but we do see with the significant amount of patients with diabetes having gastroparesis, it's not generally something that you want to hone in on as the primary issues. On the future side, further classification of gastrointestinal sensory motor disease is definitely needed to help characterize better and obtain the correct treatment for each of these pathology. Patient selection for pyloric treatment is very important, and there's definitely a large amount of studies really coming out and a lot in process. Long-term data is definitely needed at this time, as a lot of the GPOM study really looks at around 1 year. There's has been a few longer study coming out, one of which is around 24 weeks, and another more recent from Czech Republic, again, actually looking at up to 3 years, and they do show potential improvement, although it's an abstract pending publication. Lastly, targeted therapy for cellular process where the root cause of gastroparesis is very important, and we're probably quite not very close to that at this point in time. As you can imagine, there's many different combination, and a lot of these diseases are multifactorial, leading to a lot of barrier to this coming out anytime soon. So the take-home points for everyone, I think the most important thing is really getting a good history, as always. A good history really helps capture all the differentials and really help set some expectation as well in terms of the disease pathology. Gold standard for diagnosis is scintigraphic gastric emptying for at least 4 hours, and a stable isotope breath test is an acceptable option if available. Endoscopy or imaging is necessary to rule out mechanical obstruction. And lastly, treatment is unfortunately limited, but current guideline recommends pharmacological therapy versus no treatment. So one of the best options really concerning the medication based on the particular symptoms that is really troubling the patient. So if it's a patient who's having a lot of nausea and vomiting, consider antiemetic. For a patient with a lot of bloating or stomach pain, consider things like nortriptyline. And lastly, definitely would consider a lot of patient for Reglan just to see if there's some improvement, as some people do actually have improvement and may not need it. And as mentioned before, these diseases unfortunately can move between functional dyspepsia and back and vice versa. So definitely one of the big things really assessing if there's anything else going on. One study I didn't particularly bring up in this was actually that there's actually a lot of study looking at IBS and biopsies, etc. One particular study looked at the EGG of the myoelectrical activity and showed that patients with myoelectrical activities actually particularly usually respond better to gastroparesis therapy over those without, suggesting that there's a lot to really learn about what is the exact etiology of the disease and how we can best treat it. Thank you so much. This concludes my talk. So any question, please feel free.
Thank you so much, Dr. Ma, for that. A wonderful overview of gastroparesis. I know we see a ton of patients both in the inpatient and outpatient settings. So this was a great overview for us as internists and very straightforward to understand. So thank you so much for doing this today. I will open it up to questions. Dr. Risk, thank you for joining us and saying hello to Dr. Ma.
Hi, how are you?
Great job, Dr. Ma. Enjoyed
Thank
the
you so much.
Thank you, Dr. Risk. Any questions before I ask my own question? I think Dr. Fruchter, let me just pull this up. Dr. Fruchter, thank you for the great talk. What % of those with gastroparesis also have obesity?
I don't think they actually particularly look at this as this was not something that a lot of the tertiary center usually have pretty severe disease, but we're in our particular center, we definitely do see a lot more diabetic population, and we definitely do see a higher BMI with those particular subgroup. So, unfortunately, there's no clear percentage, as mentioned before. One of the biggest barrier for well, actually, I did not mention this particularly, but diabetic gastroparesis is one of the biggest challenges that a lot of time we recommend glycemic control, which is not as easy as it sounds, and this can delay further diagnosis of gastroparesis. And we do actually see some patients with better glycemic control do have improvement in their gastroparesis. So it's not the most straightforward aspect of the disease.
Thank you, Dr. Ma. I actually have a question particularly regarding the overlap of malignancy-induced gastroparesis. And I think there's not much awareness about, cancer-related gastroparesis, particularly in cancers of the upper GI tract, pancreatic cancers. I think a lot of times because of the overlap in symptoms and, chemotherapy-induced nausea and vomiting, is there something you can recommend? I mean, I particularly am biased because I'm going into oncology, so I would, want to highlight patients that are at risk for gastroparesis, instead of kind of, saying the symptoms are secondary to chemotherapy or the underlying cancer and cancer-induced cachexia. Is there anything specifically that you can highlight in the symptoms for primarily patients with upper GI cancers that would point you more towards a gastroparesis picture rather than symptoms secondary to cancer itself?
That's a great question, and actually a very challenging topic, because a lot of these type of patients with the upper GI tract malignancy, our biggest concern is mechanical obstruction from the mass effect. So it would be very challenging to really rule that out in an active disease. And there's, for those particular disease, there are a lot of other options that we can offer, such as gastroenterostomy endoscopically. To really look into paraneoplastic process of gastroparesis is obviously going to be very challenging to differentiate. And I don't think there's a great way to do so unless after a diagnostic study showing that there's really no obstruction. And even then, it becomes a question of how much they will respond to their chemotherapy, or if they're ever going to be a surgical candidate to consider other treatment options. So, unfortunately, at this time, there's no great way of really treating these patients other than making sure that it's not a mechanical obstruction and that they are not amenable to some form of procedure to prevent further gastric outlet obstruction-induced symptoms.
Absolutely. I think the one thing is a lot of the treatments that you mentioned, including pharmacologic Reglan and nortriptyline, they do overlap in oncology. So I know a lot of oncologists use that for, nausea and vomiting, and at least I guess there's that. But I agree, probably a very challenging overlap to kind of differentiate. But thank you. I think Dr. Kwok, referring back to Dr. Fruchter's, maybe look at lean and obese diabetics with gastroparesis and inflammation. I think Dr. Kwok, you're referring to maybe some ways that we can differentiate, the correlation between obesity and gastroparesis. Is that correct? I'll give Dr. Kwok a second. Any other questions for Dr. Ma?
Yes, ways of looking at the inflammatory elements that might be involved. They may be different in those that are obese and has gastroparesis as opposed to those that are lean with gastroparesis.
It's definitely very fascinating because, even in a pretty significant population of type 1 diabetics who are on the leaner side, unfortunately have a significant amount of neuropathy. So that would be a very interesting approach to get a deeper biopsy to really compare the two groups to see. But
Great point, Dr. Kwok. Thank you. Okay. If there are no other questions, I usually give it about 30 seconds. Thank you again, Dr. Ma, for joining us back at MSBI. We always love having our alumni here and seeing all the wonderful things that they're doing at other institutions. And thank you everyone for joining and saying hello to Dr. Ma. If no other questions, I guess I will end it at that. Thank you so much, everyone, and we'll see you not next week, which is Memorial Day, but the week after for our Department of Medicine Grand Rounds. Thank you again, everyone.
thank you,
Dr. Ma.
so nice to see all the familiar faces. Have a good one. Thank you.
Bye.